Welcome to the deep dive. Imagine just for a moment that sudden, unpredictable jolt of a seizure, that abrupt loss of control and the profound ripple effect it creates, not just for the person, but for their family, their daily life, really their whole future. It's a daunting reality for millions. Today, our mission is to embark on an unparalleled deep dive into a really complex and critically important area of medicine. Anti-seizure medications. Our goal isn't just to skim the surface. No, we're going to unpack this intricate field layer by layer. We're aiming to transform this dense collection of scientific articles, all the research, into clear, actionable knowledge. You should walk away from this feeling truly well-informed, almost like you've achieved a kind of professional mastery in this field.
Exactly. We've meticulously curated an exceptionally rich set of source materials for today. We'll delve into the very foundations, from the precise definitions of epilepsy and its myriad seizure types, right through to the intricate molecular mechanisms by which these powerful medications actually work. We'll even explore the critical nuances of their interactions with other drugs, potential side effects, and the broader clinical considerations that guide real-world patient management. Our aim is to connect every single one of these dots, providing a truly holistic, exhaustive understanding that goes way beyond the surface-level stuff you might typically find.
Okay, so let's start right at the absolute beginning. Let's define our terms, build a strong foundation here. What exactly is epilepsy? We're talking about a chronic disorder of the brain, and it's fundamentally defined by recurrent, and this is key, unpredictable seizures. And it's not some rare condition either. It's surprisingly common. It affects about 1% of the global population. Just to put that into perspective, that makes epilepsy the fourth most common neurologic disorder, right after migraine, stroke, and Alzheimer's disease. So yeah, it's a significant public health challenge.
It really is. And what's truly fascinating here is grasping that a seizure itself is essentially a transitory alteration in behavior, sensation, or consciousness. This alteration is directly caused by an abnormal, highly synchronized electrical discharge within the brain's networks. But it's not a singular phenomenon. The underlying causes, what we call the etiology, are incredibly diverse, and this often dictates the specific type of epilepsy and critically how we approach treating it. When we categorize the origin, we mainly look at a few distinct groups. First, there's what we call symptomatic epilepsy. This is where the epilepsy is a direct, traceable consequence of some identifiable brain damage or a structural issue. You can think of it like a clear footprint of an injury leading to the seizures. For instance, someone might develop symptomatic epilepsy after, say, a severe traumatic brain injury or a stroke that leaves damaged tissue. Various central nervous system infections like encephalitis or meningitis, or even the presence of a brain tumor disrupting normal electrical activity. And also specific congenital conditions like cortical malformations where the brain's outer layer didn't form quite right, or vascular malformations like AVMs can also be direct root causes. They leave this discernible structural mark that then leads to the recurrent seizures.
Okay, so that's when there's a clear physical cause. What about other types?
Right. Next, we get into genetic epilepsy. This is a category where inherited genetic factors are seen as the primary drivers. Historically, you might have heard the term idiopathic generalized epilepsy, or IGE, which kind of implied an unknown cause. While you might still see IGE used, the more current and precise classification is genetic generalized epilepsy, or GGE. This explicitly recognizes the genetic basis. Now, it's important to understand this isn't usually a simple single gene defect following, straightforward inheritance patterns. More often, the genetic influence is quite complex. It involves multiple genes working together, what we call oligogenic or polygenic inheritance. It's actually pretty rare to find a clear single gene defect as the sole cause.
So multiple genes are usually involved. What are
Right.
some examples of these GGEs?
Sure. Examples of epilepsy syndromes under the GGE umbrella include things like childhood absence epilepsy, which you see as brief staring spells, juvenile myoclonic epilepsy, where people have sudden, brief muscle jerks, often in the mornings, juvenile absence epilepsy, and also cases where generalized tonic-clonic seizures are the only seizure type without other kinds happening. And then there's a third category, often the most severe and challenging, the developmental and epileptic encephalopathies, or DEs. These represent the most intractable forms of epilepsy. They're characterized not just by severe, difficult-to-treat seizures, but almost always by significant developmental delays and intellectual disabilities. These often get progressively worse over time. Essentially, in DEs, the epilepsy itself is thought to contribute to or exacerbate the brain dysfunction. It's a really difficult situation.
Wow, so the seizures themselves worsen the underlying condition.
Exactly. And DCs can be subdivided further. Some are acquired DEs, meaning they stem from specific events causing profound brain injury. Think hypoxic ischemic encephalopathy, which is brain damage from lack of oxygen, often around birth, or perinatal stroke, severe brain infections, or significant head trauma. In other cases, the DE is an intrinsic part of a broader genetic syndrome that also involves other brain abnormalities. A key example here is tuberous sclerosis complex, or TSC. That's a genetic disorder where these benign, tumor-like growths called hamartomas affect multiple organs, including the brain. These brain lesions are a direct cause of the severe, often intractable epilepsy seen in TSC.
Can you give us a few more examples of these specific DEEs, just to get a clearer picture?
Absolutely. So prominent examples include Lennox-Gastaut syndrome. This is a severe childhood onset epileptic encephalopathy. It can have multiple causes and presents with various seizure types and distinct EEG patterns. Then there's Dravet syndrome, a severe myoclonic epilepsy starting in infancy, often linked to mutations in the SCN1A gene. That gene encodes a sodium channel. About 79% of Dravet cases have this genetic link. We also have CDKL5 deficiency disorder from CDKL5 gene mutations and PCDH19 clustering epilepsy linked to PCDH19 mutations. Both lead to complex seizures and developmental delays. Another distinct one is GLUT1 deficiency syndrome. This involves mutations in the SLC2A gene for the glucose transporter protein. Impaired glucose transport into the brain leads to energy deficits and seizures. And of course, infantile spasms, also known as West syndrome. This is a devastating epilepsy syndrome in infants that can also arise from many different underlying causes. In all these DEEs, the epilepsy isn't just a symptom, it's an active contributor to the neurodevelopmental problems, making them incredibly tough to manage.
Okay, so we've established that these medications are crucial for the chronic long-term management of epilepsy. But you mentioned they have other roles too, right? In more acute settings, not just for people with epilepsy.
Yes, absolutely. Beyond chronic epilepsy, these medications are indispensable for acute seizure prevention when epilepsy isn't the main diagnosis. For instance, in severe acute illnesses like meningitis, where brain inflammation creates a high seizure risk, or maybe following neurosurgery or major traumatic brain injury, in these cases, ASMs are often given prophylactically, preventatively. The goal is to stop symptomatic seizures, those caused by the acute insult, not treat a chronic brain disorder.
Got it. So preventing seizures caused by a temporary problem.
Exactly. And they're also vital for managing acute repetitive seizures, often called seizure clusters. These are periods where someone has seizures more frequently than usual. The meds aim to stabilize things before these clusters escalate into an emergency like status epilepticus. And of course, they're critical for terminating ongoing seizures and emergencies. This includes life-threatening conditions like status epilepticus, that prolonged seizure or series of seizures without recovery, or prolonged febrile seizures in kids, neonatal seizures, or even after exposure to nerve toxins. Here, rapid ASM administration is about immediately stopping that runaway electrical activity to prevent brain damage.
Okay, but there's a key point here too, right? What if the seizure is caused by something else entirely, like a metabolic issue?
Yes, that's a crucial caveat. If a seizure is primarily caused by an acute toxic or metabolic disorder, say dangerously low blood sugar or calcium, the primary therapy has to be correcting that specific underlying problem first. The ASM is more like a temporary stabilizing measure in that scenario. You always want to address the root cause if you can.
Okay, that makes perfect sense. So we know what epilepsy is, the different causes, the difference between acute and chronic use. But you mentioned seizures manifest differently. So classification must be really important, because how can you treat it if you don't know exactly what kind of seizure it is?
That's absolutely fundamental in epileptology. Understanding seizure classification isn't just academic, it's crucial because it directly guides medication choice and the overall treatment strategy. The International League Against Epilepsy, the ILE, provides the standard classification. They categorize seizures into two main types: focal onset seizures and generalized onset seizures. Let's unpack focal onset seizures first. These used to be called partial onset. Their key feature is they originate from a specific network within one hemisphere of the brain. Within this focal category, we have subtypes based on consciousness during the event. Focal aware seizures, previously simple partial, are those where consciousness is fully preserved. The person might experience odd sensations like smells or tastes, specific movements like a twitching finger, maybe unusual thoughts, but they're fully aware and remember it. In contrast, focal impaired awareness seizures, formerly complex partial, involve an impairment of consciousness. The person might seem dazed, confused, or do repetitive, non-purposeful things called automatisms like lip smacking, fiddling with clothes, maybe mumbling. They usually don't remember the event afterwards.
And these focal seizures can spread, right?
Exactly. That's a critical point. Focal seizures are dynamic. They can, and often do, spread to involve both brain hemispheres. When that happens, we call it a focal to bilateral tonic-clonic seizure. This used to be termed secondarily generalized. Thinking back to that case study in our materials, the woman with 1 to 2 minutes of altered consciousness with lip smacking, those were classic focal impaired awareness seizures.
Okay, that clarifies the focal types. What about the other main category? Generalized onset.
Right, generalized onset seizures. These are fundamentally different because the abnormal electrical activity involves both brain hemispheres right from the very start. The whole brain is essentially engaged simultaneously. And here, too, we have several distinct subtypes. The one most people probably picture is the generalized tonic-clonic seizure, formerly known as grand mal or primary generalized tonic-clonic. It's dramatic. The person abruptly loses consciousness, often falls. Then comes the tonic phase, body stiffening, lasting a few seconds, followed immediately by the clonic phase, rhythmic jerking of limbs and trunk. The whole convulsion is usually less than 3 minutes, but it's always followed by a peristictal period. Confusion, tiredness, maybe a headache, lasting minutes to hours. These are common in genetic generalized epilepsies.
Okay, the classic convulsion. What else falls under generalized onset?
Then you have generalized absence seizures, historically pédiment. These are very different. Brief episodes of unconsciousness, usually 4 to 20 seconds, often less than 10. No warning and immediate resumption of consciousness afterwards, no postictal state. It looks like they just zone out. Most common in kids, often starting between 4 and 10, especially in childhood absence epilepsy, and thankfully they often resolve by age 12. Epileptic spasms, like in infantile spasms or West syndrome, involve sudden, brief flexions, extensions, or mixed movements, mainly of the trunk and limbs close to the body, often called jackknife movements. But they can also be subtle, just grimacing, a head nod, or slight eye movements. These are very concerning because of their link to severe developmental issues.
Okay, so spasms are another distinct type.
Yes. Then myoclonic seizures. These are sudden, super brief, less than 100 milliseconds involuntary muscle contractions, single or multiple. It can affect the trunk, limbs. They're different from clonus because they're less repetitive, more like a sudden, shock-like jerk. Atypical absences are different from the typical ones we just discussed. You see these more in DEEs, like Lennox-Gastaut syndrome. The loss of awareness starts and ends less abruptly, often a more subtle, prolonged alteration of consciousness. And finally, atonic seizures, often called drop attacks. These mainly occur in Lennox-Gastaut. It's a sudden, complete loss of muscle tone, causing the person to just collapse, often leading to injuries.
And you mentioned some syndromes involve multiple seizure types.
Absolutely, critical point. Many epilepsy syndromes feature multiple seizure types in the same person. Lennox-Gastaut, Dravet syndrome, juvenile myoclonic epilepsy, these are all prime examples where patients might have tonic-clonic, myoclonic, and atypical absence seizures. This makes accurate diagnosis and tailored treatment particularly complex and really highlights why precise syndromic classification is so vital.
So we've identified the challenge, these unpredictable seizures in all their forms. Now, what's the strategy? How do we treat chronic epilepsy?
Right. The primary goal in chronic treatment with anti-seizure medications, ASMs, is simply to prevent seizures from happening, and these are mostly given orally for long-term management. Now, medication selection is key. The choice depends critically on the seizure type or the overall epilepsy syndrome classification, and we've made good progress. About 2/3 of patients can achieve adequate seizure control with the right ASM choice.
2/3 is pretty good, but what about the rest? And do you always use just one drug?
Good questions. Ideally, we prefer monotherapy using a single medication, especially for patients not severely affected or newly diagnosed. The big advantage is fewer side effects and simpler management. However, for those with hard-to-control seizures, what we call refractory seizures, we often need polytherapy using multiple medications at the same time. This leads us to the concept of pharmacoresistance. That's formally defined as failing to achieve seizure control after adequate trials of 2 or more appropriate medications, alone or together. We don't fully understand the basis for pharmacoresistance yet, which makes these cases really challenging.
Are there specific conditions known to be harder to treat?
Yes, definitely. The developmental and epileptic encephalopathies, Lennox-Gastaut, Ohtahara, infantile spasms, Dravet, CDKL5 deficiency are notoriously difficult to treat with medications alone. Some focal seizures can also be very refractory.
So if medications aren't enough, or in specific cases, what else is in the toolkit?
We have several other important strategies. One major one, potentially curative, is surgical resection. Literally removing the brain region where seizures start. The most common is temporal lobe resection for mesial temporal lobe epilepsy. Resections outside the temporal lobe are done but tend to be less successful overall. Importantly, if seizures come from a specific identifiable lesion like an injury, malformation, tumor, or vascular issue, then a targeted lesionectomy, just removing that lesion, can often be curative.
Surgery is a big step. What about less invasive options?
Yes. There's the field of electrical stimulation devices, or neuromodulation. The vagus nerve stimulator, VNS, is an implanted device with an electrode around the left vagus nerve in the neck. It delivers continuous open-loop stimulation. It's approved for drug-refractory focal seizures, but it's also valuable for some generalized epilepsies like Lennox-Gastaut, especially for reducing those difficult atonic seizures. Then there's the responsive neurostimulator, RNS. This is a smart, closed-loop system. It actually detects abnormal electrical activity in the seizure focus and then delivers stimulation to prevent the seizure. It's designed for medically refractory focal epilepsy. And the third is deep brain stimulation, DBS. This involves implanting electrodes, usually in the anterior nuclei of the thalamus, delivering open-loop stimulation. It's an adjunctive therapy for focal seizures. Interestingly, research suggests stimulating other targets, like the centromedian nucleus, might be better for generalized seizures and Lennox-Gastaut, though that's not currently approved.
Fascinating technology. What about non-drug, non-device approaches?
Absolutely. Dietary therapies can be surprisingly effective, especially in refractory epilepsy. The most well-known are the ketogenic diets. These are very high-fat, low-carb, controlled protein diets. The metabolic shift, producing ketones for brain energy, has significant anti-seizure effects. They're particularly helpful in myoclonic epilepsies, infantile spasms, Dravet syndrome, and seizures linked to tuberous sclerosis complex. In fact, the ketogenic diet is the recommended first-line treatment for GLUT1 deficiency syndrome due to that impaired glucose transport into the brain we discussed. While most common in children, adults can definitely benefit too. It shows how powerful nutrition can be.
Okay, this is where it gets really interesting for me. How do these medications actually work? What's happening at the molecular level in the brain to stop a seizure? It sounds like incredibly precise intervention.
It really is, and understanding these mechanisms is key to that professional level comprehension. ASMs work by interacting with specific molecular targets in the brain's circuitry. The ultimate effect is basically twofold. First, they inhibit the local generation of seizure discharges. They do this by reducing the ability of neurons to fire action potentials at those excessively high rates seen in seizures. They also help reduce abnormal neuronal synchronization, preventing large groups of neurons firing together inappropriately.
Okay, stop it from starting. What's the second part?
Second, they inhibit the spread of epileptic activity. This means stopping that abnormal discharge from propagating from its origin to nearby or distant brain areas. They achieve this either by strengthening the brain's natural inhibitory mechanisms, primarily those using the neurotransmitter GABA, acting like brakes, or by reducing glutamate-mediated excitatory neurotransmission. Glutamate is the main go signal, so they dampen that down.
So dampening the go signals or boosting the stop signals. Can you break down the main ways they do that?
Sure. We can broadly categorize the key molecular actions into four main strategies. First, modulation of voltage-gated ion channels. Many ASMs target the tiny pores controlling ion flow sodium, Na+, calcium, Ca2+, or potassium K+ channels, which are crucial for electrical signaling. Second, enhancement of fast GABA-mediated synaptic inhibition, boosting the effect of GABA, the brain's main inhibitory chemical. Third, modification of synaptic release processes, affecting how chemical messengers, neurotransmitters, are released between neurons. And fourth, diminution of fast glutamate-mediated excitation, turning down the volume of glutamate, the main excitatory chemical. At the very heart of it all is the excitation-inhibition balance. Seizures happen when this balance tips towards too much excitation, or not enough inhibition, or both. So the goal of the treatment is always to restore that balance, either inhibit the excess excitation or enhance the insufficient inhibition.
Okay, so how do they specifically inhibit excitation?
Well, one way is affecting the intrinsic excitability of excitatory neurons. Sodium channel blockers are a prime example. They stabilize the inactivated state of these channels, making it harder for neurons to fire rapidly and repetitively during a seizure. Another way is acting on excitatory synaptic transmission itself, maybe by modifying glutamate release or by blocking glutamate receptors like the AMPA receptors, which drugs like perampanel do.
And enhancing inhibition, how does that work?
Enhancing inhibition primarily involves boosting the activity of GABA receptors. These are the main mediators of fast inhibition in the cortex. We see this with several drug types. Positive allosteric modulators of GABA receptors, drugs like benzodiazepines, phenobarbital, and ganaxolone. They don't activate the receptor directly, but they bind to a different site and make GABA's own inhibitory effect stronger when it binds. They sort of fine-tune it, increased GABA availability. Other drugs increase the amount of GABA itself. Tiagabane blocks GABA reuptake, leaving it in the synapse longer. Vigabatrin inhibits the enzyme that breaks GABA down, so it accumulates. Potassium channels, Kv7 type. Certain potassium channels, the Kv7 type, also help stabilize neurons. Retigabine, though discontinued, worked by opening these channels, enhancing their natural inhibitory influence.
Now, this is a fascinating frontier. Instead of just stopping seizures, can we actually target the underlying disease process itself, like fixing the root problem?
That's exactly the goal of this more specific approach, aiming to reduce or eliminate seizures and associated issues by tackling the root cause. Right now, this targeted strategy has really only been successfully demonstrated in one condition: tuberous sclerosis complex, or TSC.
Right, you mentioned TSC earlier with the hamartomas.
Yeah.
How does the targeted therapy work there?
Okay, so TSC is caused by mutations in the TSC1 or TSC2 genes. These genes normally regulate a protein complex called mTORC1. In TSC, these mutations lead to mTOR signaling being constantly on. mTOR controls cell growth and proliferation. This overactive signaling drives the formation of those hamartomas, including the brain lesions that cause epilepsy. The breakthrough drug is everolimus. It's a rapalog, an analog of rapamycin. It works by inhibiting mTORC1. By precisely targeting this overactive pathway, everolimus directly addresses the underlying problem in TSC, and the result: a significant reduction in seizures for these patients. It really highlights the potential of targeting the actual disease mechanism, not just the symptoms. It's a beacon for personalized medicine in epilepsy.
That's incredible, a truly targeted approach.
It is. And one final point on mechanisms, it's worth noting that for some drugs, like valpro, zonisamide, or rufinamide, we don't have a single agreed-upon molecular target. Their broad effectiveness suggests they might work through multiple pathways. And others, like topiramate, felbamate, and cenobamate, are known to hit multiple targets, likely explaining their broad-spectrum activity. It adds another layer of complexity.
Okay, so we have a solid grasp on how they work at the cellular level. But what about the journey through the body? How do these drugs get absorbed? How long do they stick around? How are they eliminated? These seem like really practical, crucial questions for safe use.
Absolutely. Understanding pharmacokinetics is essential for effective and critically safe dosing, especially since chronic use is key to preventing potentially life-threatening seizures. The core principle is maintaining adequate drug exposure continuously within a therapeutic range. But many ASMs have a narrow therapeutic window, a small difference between an effective dose and a toxic one. This demands precise, individualized dosing.
Right, the dose has to be just right. So walk us through the journey.
Okay. First, for oral meds, they need good oral bioavailability, meaning a good chunk gets into the bloodstream. Then they have to cross the blood-brain barrier to work. Once in the body, most distribute into total body water. Their clearance from plasma is generally slow, making many medium to long-acting, often dosed twice or thrice daily. Some, like zontisamide and perampanel, have really long half-lives, over 12 hours, allowing once-daily dosing, which helps with compliance, and extended-release forms help smooth out levels for drugs with shorter half-lives.
Are there other factors affecting dosing?
Definitely. Some drugs have nonlinear kinetics. Phenytoin is the classic example. Its metabolism gets saturated at therapeutic levels. Small dose increases can cause huge jumps in blood levels and quick toxicity. It shifts from first-order to zero-order kinetics. Gabapentin also has nonlinear absorption. And of course, problems with liver or kidney function can drastically change how a drug is cleared, requiring careful dose adjustments.
That sounds complex, especially phenytoin. What about interactions between drugs? That must be a huge issue if people are on multiple meds.
It's a critical issue. Drug interactions are very common with ASMs, especially since polytherapy is frequent. It can get intricate. Adding a new drug might speed up or slow down the clearance of an existing one. Many ASMs like carbamazepine, oxcarbazepine, phenobarbital, phenytoin, primidone are potent enzyme inducers. They rev up liver enzymes like CYP450, speeding up the metabolism of other drugs, potentially making them less effective. Conversely, a new ASM might be an enzyme inhibitor, slowing down metabolism and increasing levels of an existing drug, risking toxicity. It's a balancing act. Drugs mainly cleared by the kidneys, like levetiracetam or gabapentin, are generally less prone to these liver enzyme interactions.
What about drugs having active forms after being broken down?
Yes, active metabolites. Drugs like oxcarbazepine, carbamazepine, primidone, clobazam. The body converts them into other compounds that are also active. Other drugs can affect this conversion or the clearance of the active metabolite. Then there's plasma protein binding. Drugs highly bound to proteins, over 90%, like phenytoin, valproate, diazepam, perampanel, they can be bumped off their binding sites by other drugs competing for those spots. This temporarily increases the free active drug level, potentially causing transient toxicity, though often the body compensates by increasing clearance.
And these drugs can affect non-epilepsy meds too.
Absolutely, a crucial one. Strong enzyme inducers can significantly reduce levels of oral contraceptives, leading to potential birth control failure. That's a vital counseling point, highlighting how far-reaching these interactions can be.
Okay, we've built an incredible foundation, definitions, classifications, mechanisms, how the body handles them. Now let's really zoom in on the specific medications themselves. We'll start with those mainly for focal seizures, then the broad spectrum ones, and then drugs for very specific situations.
Perfect. This detailed look will highlight the unique properties, benefits, and challenges of each one, really reinforcing why precise diagnosis and tailored treatment are absolutely critical in practice. #UI. Medications used primarily for focal, partial onset seizures. Let's start with carbamazepine. This is really the prototype sodium channel blocking ASM for focal onset seizures. It's effective for both focal seizures and those that spread to become bilateral tonic-clonic seizures. Beyond epilepsy, it's actually the first choice for the intense pain of trigeminal neuralgia, and it's also used as a mood stabilizer for bipolar disorder. However, a really important caution. Carbamazepine can worsen myoclonic and absent seizures in genetic generalized epilepsy, so it's generally avoided there. Chemically, it's an imidazolbine related to tricyclic antidepressants, but doesn't affect monoamine transporters like they do.
Okay, the prototype sodium channel blocker. How exactly does it block those channels?
Its mechanism is quite elegant. It preferentially binds to and stabilizes the inactivated state of voltage-gated sodium channels. This leads to what we call use-dependent blocking. It inhibits neurons firing at high frequencies, like during a seizure, much more effectively than those firing normally. This allows seizure control without major disruption of normal brain function. It's also voltage-dependent, working better when the neuron is depolarized. It doesn't directly change synaptic responses, but reduces transmitter release by affecting the action potentials. In animal tests, it's active in the MES test, confirming its sodium channel action, but not the PTZ test.
And how does the body handle it? Pharmacokinetics.
It has nearly 100% high bioavailability, but absorption rate varies. Peak levels can take 6-8 hours. Food slows absorption, reduces peaks, which can improve tolerance. Extended release forms also help with side effects. Distribution is slow, and it's about 70% bound to plasma proteins. A key feature is autoinduction. Carbamazepine induces its own metabolism over the first few weeks, so its half-life drops from maybe 36 hours initially to 8-12 hours with ongoing therapy. This means you have to adjust the dose significantly as you start treatment. It's mostly metabolized in the liver, with the main active metabolite being carbamazepine 10,011 epoxide, primarily formed by CYP3A4.
So that autoinduction means dosing needs careful management at the start. What are typical doses?
Right. It's usually given twice daily. Kids, 15-25 millicurie a day. Adults, typically 800-1200 millicurie a day, sometimes up to 1600 millicurie a day, rarely higher. Therapeutic trough levels are usually 4-8 millicurie ml. Slow initiation is really crucial to minimize side effects and manage that autoinduction.
Interactions. It sounds like it would interact with a lot, being an inducer.
It does. It induces CYP3A4 and CYP2B6, so it speeds up the metabolism of many other drugs, including other ASMs like primidone, phenytoin, ethosuximide, valproate, clonazepam, perampanel, ganaxolone, potentially lowering their levels. Conversely, valproate can inhibit its clearance, while phenytoin and phenobarbital can decrease its levels via their own induction effects.
What about side effects?
The many are dose-dependent. Mild GI issues, dizziness, blurred vision, double vision, diplopia, and ataxia, poor coordination. Sedation usually only at high doses. Rarely weight gain. Diplopia is often the first sign and might be transient or managed by adjusting dose timing. A benign drop in white blood cells can happen, usually not needing action unless neutrophils get very low. Rash and low sodium levels, hyponatremia are common reasons to stop the drug. And the most serious, though rare, is Stevens-Johnson syndrome, SJS, a severe skin reaction. The risk is much higher, about 10 times, in people with the HLA-B1502 allele. Testing is recommended for people of Asian descent before starting due to higher prevalence of this allele.
Okay, so that's carbamazepine. What about oxcarbazepine? You mentioned it's related.
Yes. Oxcarbazepine is a 10-keto analog. A key difference is it can't form that epoxide metabolite. It was hoped this would mean fewer side effects, but the evidence for better tolerability isn't overwhelming. Oxcarbazepine is a prodrug. It's rapidly converted by reductase enzymes to its active metabolites, S++ and R-licarbazepine, or MHDs. These MHDs block sodium channels just like carbamazepine. The parent drug's half-life is very short, 1–2 hours, but the active MHDs last 8–15 hours, a big advantage. Oxcarbazepine does not auto-induce its metabolism, leading to more predictable levels. It's mainly cleared by the kidneys, which also means fewer drug interactions compared to carbamazepine. But importantly, it can still reduce the effectiveness of hormonal contraceptives.
Is it as strong as carbamazepine?
It's generally considered less potent. You often need about 50% higher doses for similar seizure control. Starting doses maybe 300–600 mg a day, titrated up to 900–2400 mg a day. Side effects are similar to carbamazepine, maybe fewer hypersensitivity reactions and less enzyme induction, but hyponatremia might actually be more common.
And then there's S-licarbazepine acetate, another related one.
Right, S-licarbazepine acetate. It's also a prodrug, specifically of the S+-licarbazepine form. The conversion is faster and almost entirely to that S+ form. Whether this selectivity offers a real clinical edge over oxcarbazepine is still debated, since both active forms seem to act similarly. Dosing is 400–1600 mg a day, needing titration for higher doses. Pharmacokinetics are similar to oxcarbazepine's active metabolite, mainly renal elimination, needing adjustment and kidney impairment. Minimal interactions with other ASMs, but phenytoin might need dose reduction, and like oxcarbazepine, it makes oral contraceptives less effective.
Okay, moving on from those carbazepine relatives, what about lacosamide?
Lacosamide is a newer sodium channel blocker, approved for focal seizures usually in adults initially, age 17+. It's often liked for its good tolerability and favorable pharmacokinetics. Its mechanism involves binding selectively to the fast inactivated state of sodium channels, like the others, but its binding is much slower, which might contribute to its profile. Doses are typically 200–600 mg a day, given twice daily. Higher doses might be used for focal to bilateral seizures, but with more side effects. An IV form is available. The oral solution contains aspartame, so that's a caution for people with phenylketonuria.
And its pharmacokinetics, you said they were favorable.
Yes. Rapid, complete absorption, almost 100% bioavailability, food doesn't matter much. Peak levels in 1–4 hours, half-life around 13 hours, no active metabolites, minimal protein binding. And crucially, it doesn't induce or inhibit CYP450 enzymes, so it has remarkably minimal drug interactions. That's a big plus in polytherapy.
Side effects.
Common ones are dizziness, headache, nausea, diplopia. A potential concern is cardiac arrhythmia, so caution is needed, especially with pre-existing heart conditions.
Okay, now let's talk about a real classic, phenytoin. You said it's the oldest non-sedating one.
That's right, phenytoin, discovered back in 1938. It's historically significant. While still used for preventing focal and generalized tonic-clonic seizures, and crucially for acute treatment of status epilepticus, it's no longer a first-line choice for chronic therapy in many places. Why? Because of its tricky side effects and significant drug interactions. It's a hydantoin chemically. The free base isn't very water-soluble, but phenytoin sodium is. There are various oral forms, extended release, prompt, suspension, chewables, plus an IV solution. There's also fosphenytoin, a water-soluble prodrug that's rapidly converted to phenytoin. Fosphenytoin is preferred for IV use, especially in status epilepticus, as it might cause less purple glove syndrome, that nasty discoloration and pain at the injection site, than IV phenytoin. It can be given IM, but that's rarely ideal for emergencies.
And its mechanism is similar to carbamazepine.
Yes, it's a potent voltage-gated sodium channel blocker, working similarly to carbamazepine by limiting high-frequency firing. It's effective for focal onset and tonic-clonic seizures, both types. But critically, it can worsen absence epilepsy, juvenile myoclonic epilepsy, and Dravet syndrome, so it should be avoided there.
You mentioned tricky pharmacokinetics and interactions. Let's unpack that. This sounds really important.
It is incredibly important. Phenytoin's pharmacokinetics are notoriously complex. Absorption depends heavily on the formulation. Time to peak levels varies wildly, 3 to 12 hours. It's highly protein-bound, about 90%, mainly to albumin. This makes it vulnerable to displacement by other drugs, like warfarin of valproate, or in conditions with low albumin liver disease. Displacement increases the free active drug level, risking toxicity even if the total level looks okay. Valproate is a double whammy. It displaces phenytoin and inhibits its metabolism, leading to potentially large increases in free phenytoin. Phenytoin is metabolized mainly by CYP2C9 and CYP2C19 to inactive forms.
And the really tricky part, the kinetics.
Yes, the nonlinear or saturation kinetics. This is crucial. At low levels, it follows normal first-order kinetics. But as levels rise into the therapeutic range, the liver enzymes get saturated, switching to zero-order kinetics. This means the liver can only clear a fixed amount per hour, regardless of concentration. The consequence: small dose increases can lead to huge, unpredictable jumps in blood levels and rapid toxicity. The half-life, normally 12-36 hours, can become much, much longer at high levels. Reaching steady state takes way longer at higher doses, maybe 4-6 weeks instead of days. This saturation is a major reason for caution.
Wow, okay, so dose adjustments have to be tiny and slow.
Exactly. Phenytoin is also a major enzyme inducer, like carbamazepine and phenobarbital. It speeds up the metabolism of many other ASMs, valproate, lamotrigine, topiramate, oxcarbazepine, etc., potentially reducing their effectiveness. It doesn't really induce its own metabolism significantly, though.
So therapeutic levels and dosing must be managed very carefully.
Extremely carefully. The target therapeutic plasma level, total phenytoin, is usually 10-20 millisig/ml. A loading dose is possible, IV phosphonetoin preferred. Adults usually start at 300 milligram a day. If seizures continue, you need higher doses. But because of saturation kinetics, dose increases must be small, no more than 25-30 milligram a day in adults, and you have to wait weeks for the new steady state before adjusting again. Jumping from 300 to 400 milligram a day is a common error that can easily cause toxicity. Compliance is also a big factor. Low levels are often due to missed doses, not poor absorption.
And the toxicity profile reflects this complexity.
It does. Early dose-related signs include nystagmus, eye movements, but that alone doesn't always mean reduce the dose. Diplopia, double vision, and ataxia, poor coordination, do require adjustment. Sedation usually only happens at very high levels. Common chronic side effects include gingival hyperplasia, gum overgrowth, hirsutism, excess hair growth, often unwanted by women, and a coarsening of facial features. Mild peripheral neuropathy can occur. Long-term use can affect vitamin D metabolism, risk of osteomalacia, and lower folate levels, though the clinical impact of low folate isn't totally clear. Rare idiosyncratic reactions include skin rash, rarely severe, fever, swollen lymph nodes, which needs careful checking, and very rarely a granulocytosis, severe drop in white blood cells.
What about those other related drugs you mentioned briefly? Mephenetoin, ethitoin?
Right, mephenetoin, ethitoin, and furosemide. Mostly historical now, not available in the US. They were analogs. Ethitoin might have avoided some cosmetic issues, but had GI and psychiatric side effects and needed QID dosing. Mephenetoin had a higher rate of severe reactions like dermatitis and a granulocytosis than phenytoin, and furosemide was linked to fatal aplastic anemia and liver failure. Their history really underscores the search for safer options. #tag22, broad-spectrum ASMs, and other key mechanisms.
All right, we've covered the focal seizure specialists, including the complexities of phenytoin. Now let's broaden our view to the heavy hitters medications effective across multiple seizure types, both focal and generalized. This category seems essential for many people.
Absolutely. These are often the cornerstones for managing more complex epilepsy cases. Let's start with valproate and divalproic sodium. This is truly a first-line, broad-spectrum workhorse. It's incredibly versatile, effective against a wide range of seizure types. And its uses go beyond epilepsy. It's a common mood stabilizer for bipolar disorder and also used for migraine prevention. Fun fact, its anti-seizure properties were discovered by accident back in the 60s when it was just being used as a solvent for other drug research.
So it covers a lot of ground. What's the difference between valpro and divalproex?
Chemically, valproic acid is a short-chain fatty acid, a liquid. Divalproic sodium is a stable compound of valproic acid and sodium valproate. Divalproex is generally better tolerated gastrointestinally. There's also an extended release form for once-daily dosing, which really helps compliance. The active part is the valproate ion itself. Its mechanism of action is still, surprisingly, considered largely unknown despite decades of use. Its broad effectiveness in animal models suggests multiple mechanisms are at play. The clinical effect often doesn't correlate well with blood levels, hinting that we might not even know the primary active species or target.
Interesting that we still don't know exactly how such a common drug works. What types of seizures is it best for?
It's widely used and very effective for myoclonic seizures, like in JME, atonic seizures, common in Lennox-Gastaut, and generalized onset tonic-clonic seizures. It's also great for generalized absence seizures, often preferred over ethosuximide if the patient also has tonic-clonic seizures. It works for focal seizures too, though maybe not quite as well as carbamazepine or phenytoin for those specifically. And 4V forms are vital for treating status epilepticus.
Okay, and its pharmacokinetics.
It's well absorbed orally, over 80% bioavailability, peak usually around 2 hours. Food can slow absorption, but improves tolerability. It's highly protein-bound, but this binding gets saturated at higher concentrations. This means the free active fraction increases disproportionately at higher doses, making clearance seem faster. Its half-life is around 9–18 hours, hence the preference for extended release forms. It doesn't distribute widely into tissues. It's extensively metabolized in the liver through several pathways: glucuronidation, beta oxidation, CYP450 oxidation. Many metabolites are formed.
What are the typical doses and levels?
You usually start low, maybe 15 milligram in kilog, and titrate up slowly to avoid GI upset. Maintenance is often 25–30 milligram a kilog, but some need 60 milligram at kilog or even more. Therapeutic levels, total valproate, are generally 50–100 milligram a kilog, though up to 150 milligram might be needed and tolerated.
Interactions must be important given its metabolism.
Very important. Valproate inhibits the metabolism of several other drugs like phenobarbital and ethosuximide, increasing their levels. It displaces phenytoin from protein binding, raising free phenytoin levels and risking toxicity. It increases the active epoxide metabolite of carbamazepine, and crucially, it dramatically decreases lamotrigine clearance, doubling or tripling its half-life. This significantly increases the risk of severe rash if lamotrigine is added without extremely slow titration.
Okay, that lamotrigine interaction sounds critical. What about valproate's own toxicity?
Common dose-related effects are nausea, vomiting, GI pain, heartburn, hence the slow start. A fine tremor can occur at higher levels. Weight gain, increased appetite, and reversible hair loss are also seen. More seriously, though rare, is idiosyncratic hepatic toxicity, which can be fatal. The risk is highest in kids under 2, especially on multiple drugs, usually within the first 4 months. Liver function monitoring is essential. Thrombocytopenia, low platelets can occur, but bleeding is rare. It can also interfere with ammonia metabolism, potentially causing hyperammonemic encephalopathy, lethargy, confusion. So it's contraindicated if someone has a known urea cycle defect.
And the biggest concern, especially for women.
Yes, teratogenicity. Valproate is a known human teratogen. First trimester exposure significantly increases the risk of major malformations, including a 6–9% absolute risk of neural tube defects like spina bifida. Also risks for heart, facial, and digital defects. Even more concerning is the impact on neurodevelopment. Exposure is linked to cognitive impairment, including dose-dependent IQ reductions in offspring and an increased risk of autism spectrum disorder. These risks mean it must be used with extreme caution, if at all, in women of childbearing potential, always aiming for the lowest effective dose and ensuring full counseling.
That's a very serious profile to consider. Okay, moving to another broad-spectrum agent. Topiramate.
Right, topiramate. Another versatile broad-spectrum drug. It's chemically a sulfamate-substituted monosaccharide used for focal seizures, primary generalized seizures, Lennox-Gastaut syndrome. It's also very commonly used for migraine prevention, and it shows effectiveness in JME, infantile spasms, Dravet syndrome, even absence seizures.
How does this one work? Also complex.
Likely multiple targets, explaining its broad action. Possible sites include voltage-gated sodium channels, certain GABA receptors, amphokinate glutamate receptors. It's also a weak inhibitor of carbonic anhydrase, which rarely causes metabolic acidosis but is part of its profile.
And dosing.
Maintenance is usually 200–400 milligram a day, but most clinicians start very low, 25–50 milligram a day, and titrate very slowly. This is crucial to minimize the cognitive side effects. It's given twice daily, immediate release, or once daily, extended release.
What about its pharmacokinetics?
Rapid absorption, about 2 hours, 80% bioavailability. Food doesn't affect it much. Minimal protein binding, 15%. Only moderately metabolized, 20–50%. No active metabolites. Mostly excreted unchanged in urine, 50–80%. Half-life is 20–30 hours in monotherapy, but drops to 12–15 hours with enzyme-inducing drugs. Kinetics are linear. Kidney or liver problems can increase levels. No major age-gender effect, no autoinduction.
And its interactions.
They're complex, mainly affecting topiramate levels itself. The big one is that topiramate can significantly reduce the effectiveness of oral contraceptives. Alternative contraception or higher estrogen doses, if over 200 milligrams a day topiramate, are often needed.
You mentioned cognitive side effects being a reason for slow titration. Can you elaborate?
Yes, cognitive side effects are probably the most common reason people stop topiramate. Things like impaired expressive language, difficulty finding words, dysnomia, reduced verbal fluency, impaired verbal memory, and just a general slowing of thought processes. Often happens without sedation. It's dose dependent, but some people are very sensitive even at low doses. Paresthesias, tingling, are also very common but often improve. Somnolence, fatigue, dizziness, nervousness, confusion can occur early on.
Are there other serious risks?
Rare but serious ones include acute myopia and angle closure glaucoma. That's an eye emergency requiring immediate withdrawal. Kidney stones, urolithiasis, occur in about 0.5–1.5% of patients, more often in men. The carbonic anhydrase inhibition can cause a mild metabolic acidosis, usually asymptomatic. Long-term effects on bone health aren't fully clear. Decreased sweating, oligohydrosis, and risk of overheating, especially in kids, is another potential issue.
Sounds like it also causes weight loss.
Yes, significant weight loss is common long-term, mainly body fat reduction. Average is about 5% baseline weight loss, peaking around 12–18 months. This can be beneficial for metabolic health, lipids, blood sugar, blood pressure often improve. However, there's a teratogenicity concern. First trimester use is linked to a 16 to 21-fold increased relative risk of oral clefts in newborns.
Okay, another broad-spectrum drug is zonisamide. Similar profile.
Zonisamide. Yes, another valuable broad-spectrum agent for focal and generalized tonic-clonic seizures, also used in some myoclonic epilepsies and infantile spasms. Its mechanism involves blocking sodium channels, but other actions likely contribute to its breadth. Pharmacokinetically, it has high bioavailability, modest protein binding, 50–60%. A big advantage is its very long half-life, 1 to 3 days, allowing once-daily dosing. It's extensively metabolized by acetylation and CYP3A4. Dosing is typically 200–400 mg a day in adults, max 600, 4 to 8 mg in kids, max 12. Drug interactions are generally minimal from zonisamide side. However, CYP3A4 inducers, carbamazepine, phenytoin, phenobarbital, increase zonisamide clearance, shortening its half-life, which might require zonisamide dose increase. Toxicity includes drowsiness, cognitive impairment, kidney stones, and potentially serious skin rashes.
It sounds like it shares some features with topiramate.
It does. Both contain sulfur. Zonisamide is a sulfonamide to chiromethasulfamate, and both have weak carbonic anhydrase activity. They share side effects like weight loss, kidney stones, and rarely oligohydrosis. The exact link to the sulfur structure isn't fully clear, though.
What about rufinamide? You mentioned it earlier for Lennox-Gastaut.
Right, rufinamide, a triazole derivative most effective for atonic seizures in Lennox-Gastaut. Some evidence for focal seizures, too, but it's only approved for LGS in the US, Europe. Its known action is blocking voltage-gated sodium channels. Dosing needs titration, up to 45 millikilojule day, max 3,200 milligrams in kids, up to 3,200 milligrams in adults, always taken with food to boost absorption. Pharmacokinetically, it has a short half-life, 6–10 hours, minimal protein binding, and is metabolized extensively but not via CYP450, mostly excreted in urine. The main interaction is that valproate can decrease its clearance, potentially needing a rufinamide dose reduction, especially in kids. Common side effects are somnolence and vomiting.
Then there's felbamate. You mentioned it has serious risks, but it's still used.
Yes, felbamate, a dicarbamate used for focal seizures and Lennox-Gastaut. Generally well tolerated, some people feel more alert on it, but it's reserved for refractory cases due to the risk of aplastic anemia and hepatic failure, which can be fatal. Despite this, thousands still use it because it works when nothing else does, requiring very careful monitoring. Its mechanism is multiple. Use-dependent block of NMDA receptors, specifically GLO-INT-B subunit ones, and also some potentiation of GABA receptors. Dosing requires slow escalation up to 3,600 milligram day usually. It's effective for various LGS seizure types, including atonic. Pharmacokinetically, it's well absorbed, partly excreted unchanged, partly metabolized by CYP3A42E1. Half-life about 20 hours, shorter with inducers. It has significant interactions. It inhibits the metabolism of phenytoin and valproate, increasing their levels, requiring dose cuts. It also increases the active epoxide metabolite of carbamazepine, even while lowering carbamazepine itself, which can cause side effects.
And the newest broad-spectrum one mentioned is cenobamate. It sounds promising, but needs caution.
Cenobamate, yes, a tetrazole alkyl monocarbamate for focal seizures. Animal models suggest broad activity. Clinically, it's shown impressively high seizure-free rates, potentially overcoming pharmacoresistance, which is exciting. Maintenance is usually 200 milligrams once daily. 400 milligrams gave modest extra benefit. Its mechanism is dual: sodium channel blocker and a low-efficacy positive modulator of GABA receptors. Pharmacokinetically, it's well absorbed, has a very long half-life, 50–60 hours, allowing once-daily dosing, extensively metabolized by various pathways including glucuronidation and multiple CYPs. Proactive dose reduction of other drugs like clobazam, phenytoin, phenobarbital is advised when adding cenobamate due to interaction potential. Toxicity involves frequent CNS side effects, especially at higher doses. Fatigue, Dizziness, somnolence, diplopia, balance issues, gait problems, dysarthria, nystagmus, ataxia. The big safety concern is DRESS syndrome. There were cases early on, but none in a large group when titration was extremely slow, starting 12.5 milligram a day, taking 11 weeks to reach 200 milligrams. So very slow titration is mandatory. It might also cause physical dependence and withdrawal symptoms, needing gradual discontinuation. Hashtag 3, ASMs with GABA-related mechanisms, beyond barbiturates, benzodiazepines.
Okay, we've hit the sodium channel blockers, the broad-spectrum agents. Now let's focus on a group that specifically targets GABA, the brain's main inhibitory system, but in ways different from the older barbiturates and benzodiazepines. More targeted inhibition, perhaps.
Exactly. These represent more refined approaches based on understanding GABAergic transmission. First, tiagabine. This is generally a second-line adjunctive treatment for focal seizures. Critically, it's contraindicated in generalized onset epilepsies because it can actually make those seizures worse. Chemically, it's designed to cross the blood-brain barrier, an analog of nipicotic acid, which inhibits GABA uptake. Its mechanism is precisely that. It selectively inhibits the GAT1 GABA transporter. This transporter normally sucks GABA back up from the synapse. By blocking it, tiagabine leaves more GABA in the synapse for longer, enhancing both regular synaptic inhibition and the background tonic inhibition. It was a prime example of rational drug design.
So boosting GABA by stopping its removal, how is it used?
As an add-on for focal seizures, you start low, 4 mg a day, and increase weekly up to maybe 1656 mg a day, usually dosed twice daily initially, then maybe 3 or 4 times daily at higher doses. Pharmacokinetically, it's well absorbed. Linear kinetics, highly protein-bound, short half-life, 5 to 8 hours, even shorter with enzyme inducers. Taking it with food helps minimize side effects by reducing peak levels. Metabolized by CYP3A, mostly eliminated in feces.
What are the side effects? You mentioned it can worsen some seizures.
Dose-related effects include nervousness, dizziness, tremor, difficulty concentrating, depression. Excessive confusion, somnolence, ataxia might mean stopping it. Rarely psychosis, uncommon rash. And yes, it can worsen myoclonic seizures and rarely cause non-convulsive status epilepticus, even in people without prior epilepsy. Careful patient selection is key.
Okay, what about vigabatrin? Also GABA-related.
Yes, vigabatrin, an analog of GABA itself, designed as an irreversible inhibitor of GABA transaminase, GABA-T, the enzyme that breaks GABA down. It's effective for focal seizures, not generalized, and notably effective for infantile spasms, especially those linked to tuberous sclerosis. However, it's usually reserved for refractory cases because of a major risk: irreversible visual loss.
Irreversible visual loss. That sounds serious. How does it work?
It's a specific, irreversible suicide inhibitor of GABA-T. It permanently inactivates the enzyme, leading to a sustained increase in GABA levels in the brain. This enhances tonic inhibition mediated by extrasynaptic GABA receptors. Only the S plus enantiomer is active. Pharmacokinetically, it's fully absorbed, peak in 1 hour. Not protein-bound, not metabolized, just excreted unchanged in urine. Half-life is short, 6 to 8 hours, but its effect lasts much longer because the body has to synthesize new GABA enzyme to recover.
And the dosing reflects this long effect.
Dosing is typically 50 to 150 mg a day for infants. Adults start 500 milligrams twice daily, often needing 2-3 coups a day total. But the biggest issue is toxicity, that irreversible retinal dysfunction. It causes permanent bilateral concentric visual field constriction tunnel vision. It can be disabling, even if the person isn't initially aware of it. Onset varies weeks to years, requires rigorous regular eye monitoring. Other side effects: somnolence, headache, dizziness, weight gain, education, confusion, psychosis can occur, making prior mental illness a relative contraindication.
That visual risk is a major trade-off.
Yeah.
Lastly, in this GABA group, ganaxolone.
Ganaxolone. It's a synthetic steroid related structurally to progesterone and allopregnanolone. It's approved as an oral suspension for seizures in CDKL5 deficiency disorder. Its mechanism suggests potential broad-spectrum activity. Its mechanism is as a GABA receptor positive allosteric modulator, but it binds at a non-benzodiazepine site. This means it acts differently from benzos and can affect GABA receptor types that benzos don't, including those involved in tonic inhibition. Despite the steroid structure, it doesn't interact with hormone receptors, which is good. Clinically, it reduced major motor seizures in CDKL5 trials, with efficacy maintained long-term. Pharmacokinetically, oral bioavailability is low, but significantly boosted by food, so it's taken with meals. Dose TID, max 600 milligrams single dose. Nonlinear absorption, highly protein-bound, 99%. metabolized by multiple CYPs, 3A45, 2B6, 2C19, 2D6, so inducers might require dose increases. Main side effect is high rates of somnolence and sedation, reflecting its GABA action.
All right, we've covered sodium channel blockers, broad-spectrum agents, and those fine-tuning GABA. Let's explore some others that work through entirely different mechanisms. It really shows the variety of strategies used to combat seizures.
It does. The search for novel targets is ongoing. First, we had retigaban, also known as ezogabine. This was unique, a potassium channel opener indicated for focal seizures. Unfortunately, it's been discontinued in the U.S. due to an unusual side effect, pigment discoloration. Its mechanism was fascinating. It opened KCNQ25, Kv7.2, Kv7.5 voltage-gated potassium channels. These channels help stabilize neurons. Opening them increased potassium outflow, hyperpolarizing the neuron, making it less excitable and reducing neurotransmitter release, including glutamate. Dosing was typically 600-1200 milligrams a day. Pharmacokinetically, absorption wasn't affected by food, kinetics were linear, minimal drug interactions, metabolized mainly by glucuronidation and acetylation, not CYPs. Toxicity included dizziness, somnolence, blurred vision, confusion, dysarthria, and some urinary symptoms. But the key issue was that blue pigmentation of skin, lips, eyes due to binding to melanin. Though cosmetic, it led to its discontinuation.
A shame about the side effect. What about parampanel? That sounds like a different mechanism, too.
Parampanel. Yes, this represents a novel class, an AMPA receptor antagonist. It's orally active, approved for focal seizures and primary generalized tonic-clonic seizures. Its mechanism is potent non-competitive antagonism of the AMPA receptor, which is the main mediator of fast excitatory glutamate signaling in the brain. AMPA receptors are critical for seizure generation and spread. By partially blocking them, parampanel reduces seizure likelihood and inhibits the spread of excitation, especially in generalized convulsions. It binds to an allosteric site, preventing the channel from opening.
How is it used?
Typical maintenance is 4, 6, or 8 milligrams once daily. Higher doses might be needed if used with CYP3A4 inducing ASMs. Pharmacokinetically, it has a very long half-life, 70 to 110 hours, allowing once daily dosing. Steady state takes 2-3 weeks, so dose changes should be infrequent. Linear kinetics. Fully bioavailable, though food slows absorption rate. Highly protein-bound, 95%. Extensively metabolized by CYP3A4 oxidation and glucuronidation.
Interactions with that long half-life and metabolism.
Yes. Significant interactions with potent CYP3A4 inducers, carbamazepine, oxcarbazepine, phenytoin, they can increase parampanel clearance by 50-70%, requiring higher parampanel doses. Strong CYP3A4 inhibitors might increase its levels. It can also decrease the effectiveness of levonorgestrel-containing contraceptives.
What about side effects for parampanel?
It's often associated with behavioral adverse reactions, aggression, hostility, irritability, anger. These are dose-dependent, more common in younger patients or those with cognitive issues, and worsened by alcohol. Other common effects are dizziness, somnolence, headache. Falls are more common at higher doses.
Okay, now let's talk about cannabidiol, or CBD. This has gotten a lot of attention.
Cannabidiol, CBD. Yes, a non-psychoactive component of cannabis sativa. It's specifically approved for seizures in Dravet syndrome and Lennox-Gastaut syndrome, and also useful in tuberous sclerosis complex seizures. The approved product is an oil-based oral solution, distinct from unregulated dietary supplements. Its mechanism of action is still largely unknown, which is a major area of research. It shows broad anti-seizure activity in animal models, but its potency seems relatively weak overall. Importantly, it's not a CB1 or CB2 receptor agonist like THC, so its effects aren't mediated through those pathways. It likely involves novel mechanisms.
But it is effective in those specific syndromes.
Yes. It provides an important option, especially when other drugs fail. It reduces convulsive seizures in Dravet and atonic seizures in Lennox-Gastaut. Dosing requires titration, typically to 10 milliglycolib a day BID, maybe up to 20-25 milliglycolib a day. Pharmacokinetically, its oral bioavailability is normally very low, 13 to 19%, due to liver first-pass metabolism. But the approved oil formulation, sesame oil, increases bioavailability about threefold by allowing some absorption via the lymphatic system, bypassing the liver initially. Taking it with a high-fat meal boosts bioavailability even more, 4-5x. So administration with food is recommended. It's metabolized mainly by CYP2C19 and CYP3A4. The major metabolite, 7-carboxy-CBD, is abundant but inactive. Significant drug interactions. CBD inhibits CYP2C19, which can drastically increase levels of N-desmethylclobazam, the active metabolite of clobazam, potentially requiring a clobazam dose reduction due to sedation. Also, using it with valproate increases the risk of liver enzyme elevations.
And side effects of CBD.
Common ones are somnolence, about 25%, decreased appetite, 19%, diarrhea, 19%, fatigue, 13%. Liver function test abnormalities are dose-dependent and more likely with concurrent valproate use, requiring monitoring.
Okay, let's circle back to the historical bedrock. Barbiturates and benzodiazepines. Older classes, yes, but you mentioned they still play crucial roles, especially in emergencies. They really laid the groundwork.
They absolutely did, and they remain relevant. First, phenobarbital. Introduced way back in 1912 as a sedative, its epilepsy use was discovered by chance. It's the oldest ASM still available. While not a first choice for chronic use in many places now due to sedation and interactions, it critically remains a first-line treatment for neonatal seizures. Chemically, it's a barbiturate, but less sedating at antiseizure doses than anesthetic ones like pentobarbital, which is used for refractory status epilepticus.
How does phenobarbital work?
Its main action is positive allosteric modulation of GABA receptors. At lower concentrations, it increases the duration the chloride channel stays open, different from benzos, which increase opening frequency. At higher concentrations, it can directly activate the receptor. It also has other actions like blocking AMPA receptors and calcium channels.
And its uses today, besides neonatal seizures.
It's effective for focal and generalized tonic-clonic seizures. Older studies showed similar efficacy to phenato and carbamazepine, but it was stopped more often due to side effects. It might help in some myoclonic seizures, but isn't first choice. It can worsen absent seizures and infantile spasms. Long-term use leads to physical dependence, and abrupt withdrawal is dangerous, can cause severe seizures or status epilepticus. Must be tapered slowly over weeks.
What about its pharmacokinetics?
Almost completely absorbed orally, peak 0.54 hours. Modest protein binding, 55%. Metabolized in the liver, no active metabolites, about 20-25% excreted unchanged in urine. Very long half-life, 75-140 hours. Takes weeks to reach steady state or wash out. Dosing is individualized, 6,200 milligram a day. Serum levels 1540 millitgml, often targeted.
And toxicity, besides sedation?
Sedation, cognitive impairment, ataxia, sometimes paradoxical hyperactivity in kids, physical dependence, as mentioned, and teratogenicity, increased risk of major malformations, especially cardiac defects, generally avoided in women of childbearing potential if possible.
Okay, then primidone, related to phenobarbital.
Yes, primidone. Chemically, 2-desoxyphenobarbital. Widely used until the 60s, then less so due to side effects. Still used for essential tremor, though. Its mechanism is unique because it's metabolized to two active compounds, phenobarbital and phenylethylmalonamide, PEMA. All three, primidone, phenobarbital, PEMA, are active. Primidone itself acts a bit like sodium channel blockers. Phenobarbital is thought to provide most of the chronic effect due to its accumulation, but primidone has its own activity too, seen early in treatment. Clinically, it works for focal and generalized tonic-clonic seizures, but often less effective overall than carbamazepine due to side effects.
How does the metabolism affect kinetics?
It's completely absorbed. Primidone itself has a shorter half-life, 6 to 8 hours. It's oxidized to phenobarbital, which accumulates slowly, and cleaved to PEMA, intermediate clearance. During chronic therapy, phenobarbital levels end up 2-3 times higher than primidone levels. Therapeutic levels target primidone, 8 to 12 millicgml, and phenobarbital, 15 to 30 millicgml. Dosing starts very low and escalates slowly over weeks to avoid acute side effects, drowsiness, dizziness, ataxia, and nausea.
Toxicity, similar to phenobarbital then.
Similar overall, but those initial side effects can be quite severe if not started slowly. Tolerance develops with slow titration. Like phenobarbital, it gets into breast milk relatively easily.
Finally, benzodiazepines. Essential for emergencies, but limited for chronic use.
Exactly. Benzodiazepines work by positive allosteric modulation of GABA receptors, increasing the frequency of chloride channel opening. Their limitations for chronic epilepsy are major. Significant sedative effects, though sometimes paradoxical hyperactivity in kids, and rapid development of tolerance, where the anti-seizure effect fades over months. So their primary role is in the initial acute treatment of seizures, status epilepticus, seizure clusters. They're rarely used long-term for chronic epilepsy.
Which specific benzodiazepines are key here? Diazepam. 4 is first line for status epilepticus, rapid onset. Rectal gel or nasal spray for acute repetitive seizures out of hospital. Highly lipid soluble, enters brain fast but redistributes quickly, limiting duration. Lorazepam. Often preferred IV for status epilepticus due to longer duration in the brain, less redistribution. Slightly slower onset, 2 minutes. Oral concentrate can be given buccally. Sublingual nasal forms exist too, less lipophilic than diazepam. Midazolam. IM midazolam is preferred for out-of-hospital status epilepticus, avoids IV delay. Nasal spray and buccal forms for acute repetitive seizures. Water-soluble initially, less injection pain, becomes lipid-soluble at body pH, rapid onset, metabolized to an active form. Clonazepam, long-acting, potent, effective for absence, atonic myoclonic seizures. Sedation is prominent, requires slow titration. Poorly form used for status epilepticus outside the U.S. Nagazepam, not in U.S., used elsewhere for infantile spasms, myoclonic seizures. Chlordiazepate diclofenac, approved in U.S. for focal seizures, drowsiness common. Clobazam, revisiting this, a 1,5,5 benzodiazepine, structurally different.
Approved in U.S. only for Lennox-Gastaut, though used for focal seizures elsewhere. Also a GABA modulator. Clinical tolerance seems less prominent. Side effects: somnolence, sedation, dysarthria, drooling, aggression. Withdrawal needs gradual taper. Metabolized by CYP3A4 to active endosmethylclobazam, dorclobazam, which has a longer half-life and contributes most to chronic effect. CBD inhibits CYP2C19, boosting norclobazam levels, may need clobazam dose cut. Clobazam moderately inhibits CYP2TD6, potentially affecting levels of drugs like phentermine, carbamazepine, clobazam, ##62. Medications for specific seizure type syndromes. That's a great overview of the older classes and their specific roles. Now let's really hone in on medications tailored for very distinct seizure types or complex syndromes. This is where diagnosis becomes absolutely critical, right?
Precisely. This is where personalized medicine truly shines in epilepsy. Let's start with medications specifically effective for generalized absence seizures. Ethosuximide. This is unequivocally the first-line treatment, especially for childhood absence epilepsy. Often used as monotherapy, unless the patient also has generalized tonic-clonic seizures, then valproate might be preferred, or ethosuximide is combined with another drug. Chemically, it's a succinimide.
And how does ethosuximide work for absence seizures?
Its primary mechanism is thought to be inhibiting low-voltage activated T-type calcium channels in thalamocortical neurons. These channels are believed to drive the characteristic 3 Hz spike wave discharges seen on EEG during absence seizures. It might affect other channels too, but T-type inhibition is key.
So it's quite specific.
Yes. Clinically, it's very effective as monotherapy for childhood absence. Also works for atypical absence and epileptic negative myoclonus. Pharmacokinetically, it's completely absorbed, peak 3 to 7 hours. Importantly, it's not protein-bound. About 20% excreted unchanged by kidneys, the rest metabolized by liver, mainly CYP3A, to inactive products. Very low clearance, long half-life, 40 hours.
How is it dosed with that long half-life?
Kids start 10-15 milligrams a day to titrate to 15-40 milligrams a day. Older kids, adults start 250-500 milligrams a day, up to max 1,500 milligrams a day. Therapeutic levels 40-100 milligrams ml, up to 150 tolerated. Linear kinetics. Though long half-life allows once daily, often given BD or TID to minimize GI upset. Drug interactions are minimal. Valpro decreases its clearance, increasing levels. That's the main one. Toxicity is usually mild. Most common is GI distress. Pain, nausea, vomiting. Others: transient lethargy, headache, dizziness, hiccups, euphoria. Serious idiosyncratic effects are extremely rare.
What about that older drug, trimethadione?
Trimethadione, historical interest only now, not marketed in U.S., was the choice before ethosuximide, but had many side effects, including day blindness, hemorrhopia.
Okay, so ethosuximide for typical absence. What about myoclonic seizures, like in JME?
For myoclonic seizures, valproate is the clear first choice. Other effective options include levetiracetam, zonisamide, topiramate, and lamotrigine.
And atonic seizures, the drop attacks in Lennox-Gastaut.
For atonic seizures, often a combination of valproate plus lamotrigine and plus a benzodiazepine is used. Topiramate, felbamate, and lamotrigine have also shown benefit. Specifically for Lennox-Gastaut, clobazam and rufinamide are approved options known to reduce atonic seizure frequency.
Now, Dravet syndrome. That sounded very severe and often genetic.
Dravet syndrome, yes, a rare, severe genetic epileptic encephalopathy starting in infancy. Diverse seizure types, often caused by mutations in the SCN1A sodium channel gene, 79% of cases. Traditional drugs, clobazam, valproate, topiramate, stiripentol, have limited efficacy. In the U.S., cannabidiol, CBD, and stiripentol have specific approvals for Dravet. And critically remember, sodium channel blocking ASMs are contraindicated in patients with SCN1A mutations, so they can worsen seizures. Genetic diagnosis is vital here.
That contraindication is key. What about infantile spasms, West syndrome?
For infantile spasms, the primary treatments are repository corticotropin injection gel, ACTH, or oral corticosteroids. ACTH's mechanism isn't fully known, and it has significant side effects. Vigabatrin is also often used, especially if associated with tuberous sclerosis, but remember the visual risk. Other ASMs, valproate, topiramate, zonisamide, benzodiazepines, might help as add-ons, but rarely stop the spasms alone. The goal is complete cessation of spasms and the abnormal EEG pattern, hypsarrhythmia.
Finally, you mentioned everolimus specifically for tuberous sclerosis complex seizures.
Yes, everolimus for focal onset seizures associated with TSC. While infantile spasms in TSC are treated as above, other seizure types occur. If refractory to standard ASMs, ketogenic diet, VNS, or surgery might be used. Everolimus, an mTORC1 inhibitor, offers a targeted approach for these refractory focal seizures. Remember, TSC involves mutations causing overactive mTOR signaling, leading to brain lesions, tumors that cause seizures. Everolimus directly inhibits this aberrant mTOR pathway by binding FKBP12, which then inhibits mTORC1. This addresses the underlying molecular pathology.
How is everolimus used?
Dosing targets a specific trough blood concentration, usually 515 ngml. Starts around 5 milligmeters once daily, adjusted based on levels and response. Pharmacokinetically, rapid absorption, 30% bioavailability, peak 1-3 hours. Metabolized mainly by CYP3A4, also a PGPP substrate. Dose reduction is likely needed with CYP3A4 inducers, phenobarbital, phenytoin, carbamazepine, etc. Half-life is 30 hours, most common side effects, stomatitis, diarrhea, fever. Increased exposure within the target range doesn't seem to increase side effects.
Wow, that was an incredible journey through the specifics of each drug and syndrome. But managing epilepsy isn't just about picking the right pill, is it? There are broader clinical aspects, long-term considerations that are just as vital. Let's touch on some of those now.
Absolutely. These are critical pieces of the puzzle impacting patient well-being, safety, and complex decisions far beyond just the initial prescription. First, therapeutic drug monitoring, PDM. Dosing often needs to be highly individualized because people handle these drugs differently. Monitoring blood levels can really help guide dosing, especially for older ASMs where we have established reference ranges, like for carbamazepine, phenytoin, valproate, phenobarbital. These ranges give us an idea of levels usually linked to efficacy and safety.
Are these ranges absolute, though?
Not at all. They're just guidelines, need to be interpreted flexibly based on the individual patient's response and side effects. TDM is most helpful when adjusting doses, maybe switching formulations, investigating breakthrough seizures, managing drug interactions when meds are added or removed during pregnancy, finding someone's personal optimal level when they're seizure-free, figuring out if side effects are drug-related, and frankly, assessing adherence, making sure the patient is actually taking the medication as prescribed.
Okay, that makes sense. Now, a really serious topic, status epilepticus. You mentioned it's an emergency.
Status epilepticus, yes, a neurological emergency, defined as an abnormally long seizure or repeated seizures without full recovery in between. It comes in two main forms: generalized convulsive SE, GCSE, obvious motor symptoms, bilateral rhythmic jerking, impaired consciousness; non-convulsive SE, NCSE, more subtle. Persistent change in behavior, cognition, arousal, maybe odd motor behaviors, with continuous seizure activity on EEG, but without major convulsions. This includes absence DC, focal NCSE, and NCSE in coma.
And treatment needs to be fast.
Extremely fast. GCSE is life-threatening. The definition has evolved. Traditionally, it was 30 minutes. Now, consensus is to start treatment at 5 minutes for GCSE, maybe 10 for NCSE, because neuronal injury risk climbs rapidly after just a few minutes. Most seizures stop on their own within 2-3 minutes. NCSE treatment is slightly less urgent, can start more cautiously.
What's the treatment strategy?
It's algorithmic. Initial treatment, first line, always a benzodiazepine. 4V, lorazepam, or diazepam are commonest. IM midazolam if no IV access. Lorazepam might last a bit longer in the brain than diazepam. Pre-hospital options include rectal diazepam, intranasal midazolam diazepam, second therapy, if benzo fails or cause isn't fixed. Because benzos wear off, a second drug is usually given. 4V levetiracetam, valproate, phosphenytoin, or phenytoin are considered equally effective, 50% success rate after benzos fail, with similar side effects. 4V phenobarbital works but causes more sedation respiratory issues. 4 lacosamide is also used, refractory SE. Seizures continue 30 minutes after both first and second therapies. Requires escalation to anesthetic infusions. Tentobarbital, propofol, midazolam, sometimes ketamine. Super-refractory SC. Continues 24 hours after anesthesia starts. Very difficult. Often requires ongoing anesthesia. For NCSC specifically, absence SC often responds to a benzo then IV valproate, followed by oral etha-6-imidazole long-term. Focal NCSE usually responds to IV ASMs without needing anesthesia. NCSE in coma is often refractory.
What about seizure clusters? Not quite status, but still concerning.
Right, acute repetitive seizures, seizure clusters. More frequent than usual, but with recovery between. The worry is they can escalate to status. Treatment can be IV benzos in the ER. Out-of-hospital options, US approved, include diazepam rectal gel, midazolam, and diazepam nasal sprays. Other routes like intranasal lorazepam or buccal midazolam are used elsewhere. Logistics matter. Lorazepam needs refrigeration, others don't. Rectal route can be difficult.
Okay, shifting gears significantly, teratogenicity on pregnancy. This is hugely important.
Extremely important. Most pregnant women with epilepsy need to stay on medication, but no ASM is completely safe for the fetus. Some carry high risk. Valproate, known teratogen. Increased risk of major malformations, spina bifida, 6-9% absolute risk. Heart facial digital defects. Critically, linked to cognitive impairment, dose-dependent IQ reduction, and increased autism risk in offspring. Phenobarbital, increased risk of major malformations as SP-marked cardiac. Topiramate, increased risk around 10x of oral clefts. Others, like carbamazepine, phenytoin, levetiracetam, have lower or less understood risks, but not zero. Generally, lamotrigine and levetiracetam are considered the lowest risk options for both malformations and neurodevelopment. Polytherapy, especially with valproate, likely increases neurodevelopmental risks. Careful planning and counseling are essential.
What about breastfeeding? Can mothers take these medications?
Generally, yes. Some drugs, primidone, levetiracetam, gabapentin, lamotrigine, topiramate, enter breast milk relatively easily. Highly protein-bound ones, valpro, phenobarbital, phenytoin, carbamazepine, don't as much. However, studies haven't shown significant adverse effects at infants, maybe some sedation with barbiturates benzos. Given the benefits of breastfeeding, it's usually not discouraged.
Another sensitive area, suicidality risk.
Yes. An FDA analysis in 2008 suggested a slightly increased risk across ASMs, leading to an alert. However, subsequent larger studies haven't found convincing evidence that ASMs as a class induce suicidal behavior. Newer ASMs also don't seem to show this risk versus placebo. What is clear is that psychiatric issues like depression are much more common in people with epilepsy. And tragically, suicide is a much more frequent cause of death, around 11.5% in this population compared to the general population, 1%. So regardless of medication, it's crucial to routinely screen epilepsy patients for depression and suicide risk.
Is it ever possible to stop taking these medications? Withdrawal.
Yes, withdrawal is possible for some, maybe not lifelong therapy. In kids seizure-free for 2 to 4+ years, about 70% remain seizure-free after stopping meds. Risk depends on the syndrome. Absence often remits, JME usually doesn't. Risk factors for recurrence, abnormal EEG, neurological issues, difficult initial control. Less data in adults, but withdrawal might be more successful with generalized epilepsies, single seizure type. Longer epilepsy duration, abnormal exam EEG, increased recurrence risk. Withdrawal must always be slow, gradual, 1 to 3+ months. Abrupt stopping risks, rebound seizures, even status epilepticus, especially with barbiturates and benzodiazepines due to physical dependence.
Finally, what's on the horizon? How are new medications developed?
Medication development traditionally relied on rodent models. MES test. Electrical shock, good for finding sodium channel blockers. PTZ test. Chemical convulsant finds drugs acting via other mechanisms like GABA. 6-Hertz test. Different electrical stimulus finds drugs for harder to treat seizures. Kindling model. Repeated mild stimuli cause permanent seizure susceptibility. Models focal epilepsy development. Genetic models. Animals prone to absent seizures, etc. More recently, in vitro screening targets specific molecules, rational design, like vigabatrin, GABA-T, tiagabine, GAT1, perampanel, AMPA receptor, brivaracetam, SB2A.
What's currently in development?
Exciting things. For focal seizures, XEN1101, KV7 opener, darigabat, selective GABA modulator, NBI 921352, selective NaV1.6 blocker. For DEs, various small molecules and gene therapies, antisense oligos, AAV vectors. For acute emergencies, inhaled alprazolam, staccato, diazepam buccal film, ganaxolone for refractory status. The pipeline is active.
What an incredible, truly deep dive we've taken today. We started right at the definition of epilepsy, explored all its forms, symptomatic, genetic, those challenging encephalopathies. We journeyed through the intricate molecular ways these drugs work and really got into the details of specific medications, how the body handles them, their interactions, side effects. You've grasped the critical difference between focal and generalized seizures and how diagnosis drives everything from monotherapy versus polytherapy right up to surgery, devices, and diet.
We really have peeled back layer after layer, aiming for that mastery-level understanding. Not just what the drugs are, but how they work, and critically, why specific choices are made. From brain chemistry balance to complex drug interactions and vital life factors like pregnancy, breastfeeding, mental health, we've aimed for that holistic, in-depth view.
You, our listener, now have a foundational understanding far beyond the typical knowledge base. You can appreciate the complexity, the precision needed to manage this condition. It really is about empowering you with detailed knowledge, helping you understand the why behind treatment plans.
Exactly. Think about how this depth of information can enrich conversations with doctors, improve understanding of care plans, or just satisfy that deep curiosity about the brain and how we can influence its functions. We've clearly seen how incredibly personalized the approach must be and how dynamic the research continues to be, always pushing forward.
So, given this immense complexity, the personalized nature of epilepsy, what future innovations do you think could truly revolutionize treatment, moving beyond just managing symptoms to maybe even preventing epilepsy from developing in the first place in those who are vulnerable?
That is the crucial question, isn't it? If we keep refining our understanding of individual genetics, the networks involved in actually becoming epileptic and identifying ever more precise molecular targets, could we one day tailor preventative therapies so accurately that seizures become an entirely avoidable part of someone's life, not just a managed condition? The pursuit of that future, well, that's what drives the entire field forward.